Okay, great. So again, welcome everyone to Bones and Joints. We'll be looking particularly at the appendicular skeleton. And when we think of the appendicular skeleton, of course, when you look at the body is made up of the axial and appendicular. The axial goes down the center, and the appendicular consists of the different girdles together with um, the bones which are attached to them. So let's see if we could arrive at those at the appendicular, because we looked at these before. So I will just browse over them as a means of revision. So of course, this is skeleton in general. We did mention in terms of the long bone. And why do they call the long bone the long bone? Again, I forgot. Why do they call the long bone the long bone?
Because it's long.
Because it's long. Some things in life are not hard at all.
Difficult.
Yeah, difficult. Thank you very much. Yeah, not at all. Right. So here's a long bone for those of us who like KFC. Right. KFC having a lot of specials now for carnival, quote unquote, since we really don't have a carnival, but we have a carnival in theory. Right. So when you're chewing on that KFC bone, the leg bone, right, yum 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 yum. Right, you're looking at the epiphysis, which is the end, the metaphysis, right, which is the middle part, and the diaphysis, which is actually the long shaft of the bone. And of course, for those of us who are into food, within the bone itself, we have blood vessels. Now, oftentimes we don't think of bone as something alive, except of course, if you broke a bone, then you'll realize how much pain and so on, and you'll be appreciative of nerves running within the bone structure itself. But the bone is very much alive. The reason why we don't think of it as being alive is most of the time we think of a skeleton, that little thing, let's say, that we see in the lab, and that is just white and it just sits there. There's no color to it. But in truth and in fact, the bone is very much alive, with the blood vessels within it, with a set of nerves, and with yellow marrow within it as well. So always do remember that when you're thinking about a bone, while it is nice to draw reference to that skeleton which is in the lab, but always think about it. It is alive. It is very much alive, most definitely. All right. So these are bone cells. We mentioned that, when we looked at it for the first time. Um, and so I wouldn't get into too much detail there. We also mentioned in terms of fracture repair, for those of us who ever had a fracture, very interestingly enough, whenever you do have a fracture or a total breakage of the bone, in truth and in fact, from a structural perspective, the bone is stronger when it is repaired, because what you have happening is you have these bone is actually laid down past the normal boundaries of that which existed before. So where that fracture existed, where the break existed, it is actually stronger, which is very incredible. And it all feeds into the fact, the body machine. I often tell you that the body is this fantastic machine. Never forget that one. All right, so we mentioned already some of the joints in our bodies. We have different types of joints. I'll just touch briefly on it. Of course, in the skull, right, we have synarthrosis, so we have these fixed joints which don't allow movement. Why do you think it will not be a good idea to have movement in your skull joints? Why would that be a bad idea? One word. Why would it be a bad idea if these joints could have moved? Let me hear you. Why do you think it's a bad idea? We might have no wrong answers.
Fracture.
Pardon?
Fracture can cause.
Fracture, yeah. In terms of movement, it'll cause fractures. Fractures could lead to damage. Remember, the major function of the skull is to protect the brain, and the brain is the seat of consciousness. So you don't want damage to occur. So if there was a fracture in terms of movement, ooh la la, that has caused damage to the brain itself. And that is a whole nother can of worms to open there in terms of complexities. All right. Very good. So we spoke about previously in terms of the movements, right? Anatomical movements. We looked at some of these yesterday in terms of the special movements associated with the head and also with the arm and leg. For those of us who actually are athletes in particular, right, you'll know about pronation and supination, right? You wouldn't want this in terms of inversion and, excuse me, eversion. Pronation is when actually, so this movement, when you have inversion, you have pronation. There's the over rotation of the joint. You wouldn't want this to occur when you're running, because this could then lead to a sprain. So in terms of pronation, it's very important to have the right type of shoes that will prevent this pronation from occurring, or that ankle joint from moving too far ahead. Okay. Different classifications of those groups. Let's see, I would probably start at this point in terms of identifying these two things, axial and appendicular. And we'll skip over the axial because we already addressed that, and we look at the appendicular. So for the groups here, it's showing on the skeletons here, we're seeing two things. One, we're seeing the axial skeleton, which is highlighted in green, and over here, we see this is the posterior view of the axial skeleton, and then the appendicular skeleton, which is a bit of what you'd call this brown in terms of the hue, right? And this is the appendicular. Notice the appendicular consists of the two girdles, the pelvic and pectoral girdles, together with the associated limb bones that come off of these girdles. So the appendicular, pelvic girdle, and all of these bones, the pectoral girdle, right, which is shown here, together with the bones of the arm and forearm, these collectively, these two, in brown, they form the appendicular. And again, showing it, this is from a rear view or posterior view. We see then the clavicle and scapula together with the arms and forearms, and then the pelvis together with the bones of the leg. All right, so if we're looking at the skull, let me just speak to that. The skull is actually part of the axial skeleton, and it's called the axial because really it forms the axis. The arms pivot around this, and the legs really pivot around the axial, this axis here. So the axial skeleton consists of the skull, the vertebral column, and of course the ribs, which come off of the vertebral column. All right, so this is just the skull. We mentioned this last day. Just to talk about it, foramen just really means a hole. And the foramen magnum, what we're looking at the skull. So if you're taking a section across the skull and we're looking down this way. So we're looking down into the spinal, towards the vertebral column. So underneath here, you'd have the vertebral column. Here you have the foramen magnum. So therefore, what do you think goes through here? What goes through the foramen magnum? What structure do you think passes through here?
The spinal cord.
Very good, yeah. So the spinal cord, right? So the spinal cord actually passes down here. So this is from the brain, it goes down. And as we mentioned previously, right, there's no break between the brain and the spinal cord, because if there was a break, what would happen? A word that begins with P?
Paralysis.
Paralysis would occur. Very good. So that's why very important to keep that in mind, that there's a continuation between the brain and the spinal cord. So the brain really, like it has a long tail. Always think about it in that regard. Right, so this is just showing the skull in sagittal section. And again, sagittal, which is this or longitudinal section. Looking at it a long way. And here again this is where the foramen magnum. So of course, this is where you get your spine. The spine actually goes down here, and protecting the spine, you'd have the vertebral column. Right, this is the frontal section. Right. And of course, when you're looking at with babies, what do you have? You have fontanelles. Right. So this is the anterior fontanelle. These are spaces. And why do we have these spaces? Why does a baby have these spaces? So why is it then that the whole skull is not fused at birth? One word.
Still in the tender stage.
Say that one more time.
Maybe the baby is still in the tender stage.
Yes. Correct. It is in the tender stage, but why does it not have a complete skull? Why isn't the
That
skull?
it could pass through the mother's passage.
Yeah, through the vaginal passage. So you're both right. It is in the developmental stage. And more importantly, the reason why is because you have to remember, relative to the size, I'm sure you've seen some babies' heads, right? When you look at the images, and so some babies have big heads. So you could only just imagine if it was completely fused in terms of the skull, that will definitely lead to vaginal tearing, right? So one of the ways in terms of back to the body, the machine, one of the ways in which it facilitates delivery in a a relatively non-painful way to the female is having these fontanelles. So literally what happens, you have deformation of the shape of this head or skull, right? It is deformed and it fits through the vaginal passage for delivery. Right, so that's one of the critical things with this. Of course, what the old people they say, how you close this up? What is one thing you could do to close up the mole of the baby head, as it's called, or the fontanelles? What could you do to accelerate the rate that these fontanelles close once the baby is born? What do you rub on it? Anybody?
Powder.
Powder, yes. But if you ask the old people, particularly, I would say in a Caribbean culture, they tell you, well, coconut oil, yes, they'll tell you that to rub coconut oil, yes.
Oh yeah, and the powder.
Oil, yes, from the coconut, right? You rub it on it, and they say that is accelerate the closing of the fontanelle. Maybe there is some truth. I've never seen a paper written on it, but seeing that it's probably handed down from generation to generation, it probably does have some truth to it in terms of accelerating the growth. Of course, the only way to test that, ideally, is if you have twins, right? If you have twins, so you have one as a control, you have one in which you don't rub the coconut oil, and identical twins are that, and then the other baby in which you rub the coconut oil, and then you could do a measure of the size of the fontanelle with time to see if that is actually correct. Yeah, so that test could only be done, in terms of to lend credibility to that statement is to get some identical twins at birth and run those tests, with one put coconut oil and with the other one don't actually do it. In terms of this is showing the length of time when it actually, in terms of for the fusion process to be completed. Some persons it fuses quite quickly. Yes, but others it takes a little longer, but this is just showing the average time for it. Okay. So coconut oil, do keep that in mind. Those are the cranial sutures. I wouldn't speak to that because we looked at that last day. All right, sacrum and the coccyx. So this is the coccyx, of course, some fused bones, right? This is the end of the vertebral column. And always be careful with it. How many of us used to play that game in school, in high school in particular, or maybe primary school, where somebody would go to sit down and then you put your foot and you pull away the chair, and they sit in the air and they drop on the ground, boot up and you laugh. Kia, 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 kia. Yeah, well, I can tell you, I've met only one person who was actually, permanently injured from that. And I mean, she's a grown woman now, but she said that happened to her in high school. Somebody pulled away the chair and she sat in the air and, went straight down to the ground. So even though it's funny, I would strongly discourage you all, now that you know better, from doing it because it could cause lasting damage. She says she does have she still has pain in her leg, from that. And that is on in terms of 10, 15 years, since that happened. So while it is funny, it does look funny, I would agree, but it could cause lasting damage. Particularly, you don't want to do that to old people. So you don't want to do that to granny, because granny do that and granny breaks her pelvis, and that's a whole nother story. All right? So we wouldn't do that to granny or to anybody else for that matter. Okay, so we'll start from here because we're looking at the appendicular skeleton. Appendicular skeleton, as mentioned before, the two girdles, the pelvic and pectoral girdles, together with the associated limbs which come off of them. So with the pectoral girdle, I'll just highlight some of the bones. You have the manubrium on the sternum. This is also known, what's the other name for your sternum? Your sternum, or what bone, is associated with a structure found on either side. particularly in females, or the term is usually used with females, your sternum or your breastbone, all right? So the sternum runs down the middle there, and it's attached to the clavicle, all right? What's the other name for the clavicle? Commonly known as the red, blue, green, yellow, orange, brown, white, collarbone. Very good. All right, so also known as the collarbone in terms of the clavicle. From the scapula, you also have the humerus, right? So the humerus, this is the bone that actually comes down here. And note that it, in terms of its articulation, it articulates very nicely. If you look at the scapula here with this glenoid cavity, do we have to get into the intricacies of the pelvic girdle? These pieces of the coracoid process, acromion, spine, and glenoid? Not for this course. You'll be doing that in a later course in terms of details. For this course, you just have to appreciate the major bones, namely the sternum, clavicle, and the humerus in terms of those which are associated with the pectoral girdle. So let's look now at the upper limb. So you have the shoulder, the arm, elbow, forearm, wrist, and hand. So these are the bones associated with the upper limb. So the humerus, let's have a little more look at the humerus, all right? So the humerus, this bone here, which is also known as shown here in the arm. So this bone, it has a head, right, anatomical neck, and a deltoid tuberosity. Those are the three parts you should pay attention to: the head, the neck, and the deltoid tuberosity. And just know that it does articulate via the epicondyle region. That's all you really have to know as it relates to the humerus. This is just showing an anterior view and the posterior view. One of the things to take note, and it's always such a marvelous thing when you do see the skeleton, is how it is so well made and put together in terms of the joints. When you look at the joint here, for instance, so here we're seeing the ulnar and the radius. So this is the forearm that we'll look at in a second. You see how well built it is. It just fits in rather nicely into these spaces of the humerus. All right, so this is the elbow joint. We don't have to get into much detail of the elbow joint, but just take note. Look at how nicely these things fit together. Is this really an engineering marvel at that regard? In terms of the ulnar and the radius, how they articulate with the head of the humerus is very impressive in that regard. Sorry, not the head, but the epicondyle region. That is higher up. This is showing the shoulder joint, and of course you do have ligaments associated with it. Anybody here played cricket in school, in high school or otherwise? Anybody played any sports?
Football?
Yes, sir.
Yes? Football? All right, that's good. Anybody played netball? Nobody played netball. Anybody played volleyball? Nobody played. Anybody played sports involving your hand?
Tennis.
Tennis. Oh, yeah. Ooh.
Yes, sir.
Oh, tennis. Yes, yes, tennis. Yes, you do get sometimes tennis elbow, and you could also get injuries related to the shoulder as well, most definitely. All right. So very importantly, in terms of these ligaments, in terms of holding that joint together, because usually when you have those injuries associated with the joints, which are not genetically of genetic origin, like rheumatoid arthritis, which usually has a very high genetic component to it. But when you could get them from repetitive motion, they call them repetitive motion injuries, such as that which exists in certain sports like tennis or volleyball. Somebody else was saying they played a sport related to using your hand. Yes? Somebody else was saying that. Which sport they were playing? Pool? All right. So maybe it was tennis as well. So that's why they did not respond. But you always have to be careful, you know, in terms of it. Warming up properly, you know, that is very essential, you know, to avoid injuries. All right. I think the world number one now is whom? Is it Naomi Osaka? I think so. In terms of from Japan, by way of America and Japan. Her father is American, her mother is Japanese. So is the Olympics going to be on? There's still a question mark over that. I think the latest thing I heard is that they want to have it closed, behind closed doors, in terms of the Olympics, right? Because of the fact, the protocol or just the arranging something where you have to cater for COVID-19 protocols is exceedingly dangerous, but not dangerous, but it's difficult, particularly for large numbers. So, we'll have to wait. We wait with bated breath to see if it does go forward. But most definitely, when you look at the Olympics, which is really the pinnacle of sporting activities or sporting endeavors for a lot of athletes, you always have to be careful in terms of always warming up properly, to reduce the risk of getting damage to these ligaments. That is very important. Ligaments, of course, hold bone to bone, tendons, bone to muscle, right? But ligaments in particular, those are the strong ones. You really don't want to get those damaged. Even in football, depending on what other sport, in any really contact sport, because if you fall, let's say, you run the risk of actually damaging your ligaments. Yeah, you could get it, indeed. All right, so the forearm now, here we're looking at the forearm. We have the radius and ulnar, as mentioned in a previous discussion. The radius, one of the ways you could actually tell which bone is the radius is usually continuous with the thumb. So that's a nice way of actually tracing it. Find the thumb, trace it, and you'll find the radius. And even when you turn your hand over, as shown here, the radius moves with it. Again, this is a fascinating engineering feat because you have that movement which occurs freely at the elbow to allow that inversion and pronation to occur. Right, so you could move your arm, have your palms upward in the anatomical position. You could turn it downward as well, and you could do that without actually moving the elbow. That is really great when you think about it. So when you look at the bones itself, you do have these notches which occur, the trochlear notch, right, which occurs at the elbow. It fits into the trochlea, which is associated with the humerus. It fits nicely in there. So you have all of these grooves associated with the forearm, and together they facilitate the movement of the arm itself. Coming down, we see here, here again, the anatomical position, right, which is hand up, palms facing up, sorry. And interestingly enough, you will learn this, some of you all might know this already. If somebody does present unconscious on a gurney, it's usual in terms of if they're lying flat down, that the palm is usually face upward. That's how it usually faces, even though you're unconscious. The fact that if your palms are turned downward, it could indicate damage to a part of the brain associated with normal posture. So even those little things to pick up on if somebody presents on a gurney, to watch the arms, of course, check for dilation of the pupils, which is what the doctor does. But simple things like that, you could actually tell if there is damage, any type of brain damage, if it is suspected. All right, so here, this is the right radius and ulnar, and here just showing again the grooves into which the head of, in this case, the head of the humerus will fit, and it just fits in so nicely. As I said, it's a marvelous feat of engineering. Let's look at the hand. All right, so how many fingers do we usually have? 5 fingers, good. Is it possible to have a 6th finger? Anybody here have, okay, you might want to talk about it. Have you ever seen somebody with 6 fingers?
Yes, sir.
Yeah, and sometimes, sometimes you can have 2 types of 6 fingers. Sometimes the 6th finger is actually like a solid finger. And then there's some which actually like is a little piece of skin and it just hang like a little, you know what I'm talking about?
Yes,
A little piece of skin and it just kind of hangs on a finger. But have some is like a definite bone, is bone associated with it, and it's just like a, it's just indeed like a finger itself. I know from experience, the ones that just hang down by a little piece of skin, how you could get that off? It's a very simple way. And no, it doesn't involve chopping it off. If the baby has it, it's just hanging down. How could you get it off? Anybody? Anybody know? In terms of, there's what the old wives or granny will tell you how you get it off. You know, if you
Well,
have
my mother had a few children with, but she cut them off. She went
oh,
to
she
the
cut it.
doctor.
Or they
Get
went
it
to the
cut.
doctor, right? You could get surgery and so on. Another
Yeah.
way you could do it, okay, but don't quote me. My grandmother tell me this one. God rest her soul. I don't know about the medical competencies of my grandmother, so this is just I just speaking from a old wife's perspective, right? But she would say how just a tie it with a string. So when you eventually when you tie it with a string, is shrivel the finger shrivel, and then it just drop off, right? It's drop off after a couple of weeks. We're talking about a baby, yeah? This is from, when a baby has a sixth finger. So you could probably check the old people or the elderly in your community or within your family, ask them about that one and see if there's any credibility to it, credence. Because there are lots of things, where you don't necessarily have to go to, to go to get surgery for. I think I mentioned previously, if you do have related to the umbilicus or your belly button, if you have a hernia, and when you have a hernia, then that just means that the muscle there is torn, right? And the literally your intestine are pushing out on it. So you get a outie, what we call a outie, your belly button push outward. I think I mentioned, I remember for my sister at least, my mother carried her to a quote unquote old doctor. This was up in St. Augustine. Dr. Warner, he used to be on the main road on the junction before before you reach UE there. But he's gone. He's been gone for quite a while. But what he told her, because my sister had an outie when she was born, he said, all right, take a 50 cents piece, wrap it in gauze and strap it to it. Right? Strap it down, and ever so often, just like every 2 or 3 days, of course, take it off, clean it, put another piece of gauze and put it back. Long story short, my sister no longer has an outie, and this was how many years ago, right? And just applying that pressure then to that area, it actually reversed it without surgery, right? And she, quote unquote, she had a normal belly button after that fact. Right. So very interestingly enough, sometimes there is credibility in what the old people say or the older doctors. So which is why in particular I would say things related to babies is always good to get the consult of an older doctor, the old school doctors, because these ones, they're quick to sometimes rush the surgery. That is my opinion, not the views of Costat. Okay, let's go forward. So here we have the hand showing the different joints. Notice your fingers, other name for the fingers, of course, is your phalanges. You have your metacarpals and the carpal bones, which are your wrist bones. Out of all of these, which one would you really not want to damage and why? Which one do you think would be the hardest ones to repair and will probably cause the most difficulty? Those located in the phalanges, metacarpals, or carpals. Which one do you think will be the most difficult to repair and why?
The couple.
Carpals. Why? No, actually, you're correct. Why do you say that? One word. Well, one out of two.
Because it's at the bottom of the wrist and it is hard to, I believe, hard to do surgery on
Yeah.
at that area.
Yep. So one word could be very simply movement. Your wrists out of your hand, you're quite right. If you think about it, you must try it. Have a look at your hand. It's very difficult to keep your wrist steady, or keep it immobile. I hear what you're saying. Well, you could put it in plaster Paris. Yeah. But you'll still have some movement in there, even though they do restrict it with plaster of Paris in that regard. So sometimes what they'll have to do is pin the bones. And the other thing is because they're so small, sometimes that could be a little tricky to heal. So of all the bones, yeah, those are the ones. The carpals are the trickiest ones. All right, so it's good to, if you got fracture your finger and so on, again, associated with sports, right? Not too much of an issue. They could heal up pretty well, but the wrist bones, yeah, those are the little tricky. They're a little trickier to heal. So very right, the carpals are the tricky ones. And because one of the reasons is because they're a little small and also because of movement. They're moving all the time. The others pivot really around the wrist, but these now, they move all the time. So it's a little more tricky. So very good. Again, as we saw with the radius and ulnar in terms of the articulation of movement, with the humerus. Same thing again in terms of engineering. Here you have the metacarpals. They have just a design so that they move very well with the phalanges, and even within the phalanges itself, you have these little joints, and these again, in terms of how they fit together, very well engineered so that it allows for pretty free movement. One of the things, another question let me ask you from an insurance perspective, which one of these fingers is the most important finger? Finger number 1, 2, 3, 4, or 5. Which one, if you lose it, they pay the most money to you for compensation because it's considered the most important finger. 1,
Yes,
2,
sir.
3, 1, 2, 3, 4, or 5.
Number one.
One. So is it your thumb, finger one?
Number
Number one.
1. Yes, quite right. You're all on the ball today. Yes, yes. The thumb, right? Because the thumb is what sets us apart. It allows you to grab things or grasp things and pick them up. It allows you for free movement. It allows you to do a lot of things. You must try it sometime. Try holding on your thumb and try to do a lot of things. You could do it, but it's a lot trickier, right? So the thumb is considered the most expensive from an insurance perspective. It's considered the most expensive finger, right? Because of the thumb, it allows us to grasp things and grasping or pick up things, and it allows for a lot of movement. The thumb. If you don't have your thumb, you can't really do a lot of things, right? Yes, it is good to have the other 4, but yeah, this one is very important. In fact, way back when I was younger, I remember seeing in this Chinese documentary, right, what they actually do for persons who lose their thumb, that they could actually take off their toe and put the big toe up here. I'm not making this thing up. It was showing neurosurgery, and they take the toe and they put it here, right, your big toe, because it's considered so important to have that movement with the thumb, right? So that's an option what they could do. I hear what you're saying. So will you tip over because you don't have a toe? Well, you could wear steel tip boots. I guess that'll give you a little bit more balance in that regard. But clearly, in terms of the two, in terms of walking with a little tip as opposed to holding things properly, well, it's considered more important, at least in terms of from that documentary's perspective that they actually did that surgery. Okay, so here we are looking at the girdle. In this case, is the pelvic girdle. And there are differences in terms of the male and female girdles. Of course, for the females, one of these things you will see, and we'll speak more to this when we're doing reproduction, but everything is larger and it's wider. So this iliac crest is more flared in the female, which gives rise to hips. So therefore, in general, when you look at females generally have broader hips than males. And that it has to do with this iliac crest. And it also has to do because of this larger area here in terms of the pelvic outlet. And this is critical, which helps, of course, in terms of the delivery process. Right? So females, in terms of, which is why if you see a skeleton, you can actually tell the gender of the person if the pelvic girdle is indeed present. Okay? So this is just showing the bones of the pelvic. Here's the pubic arch. Of course, with females, it will be wider because of the fact you have these bones set apart further. So all of these things. Yes, go ahead.
I think somebody's trying to get into class.
I think I'll allow them in. I'm not seeing anybody right now.
All right.
Yeah, but good looking out for your peeps. I am mad at you. All right. Yeah, I'll allow in somebody. So maybe they sent an email in the during the time. Yeah, I'm not seeing anybody currently. Come in.
Okay, then. Yeah. All right. Thanks.
Okay, you're welcome. All right. So this is showing the girdle itself. Again, notice in terms of engineering how well it's put together. Here's the acetabulum. Again, this allows pivoting with the femur. So this is very important. The ball of the femur actually pivots quite nicely here, and the acetabulum, right? It allows then free movement of the femur itself. So these are the other bones associated with the pelvic girdle. Now, notice that the pelvic brim. Anybody? Where is the pelvic brim? Anybody seeing it? No, I am not seeing it. But the pelvic brim is actually Let me see. It should be. Oh, here it is, the pelvic brim.
Here.
Yes, this is it here, the pelvic brim, right? It defines the pelvic inlet. So that's the top, right? Going around there, the pelvic brim. The pelvic brim is very important. One of the things that is important is an important anatomical landmark, right? So usually, you look for the pelvic brim, which is the rim of the pelvis. Oops, sorry. And then relative to this, you could look and say, okay, well, up here is the iliac crest. Right around, of course, this whole thing would be the pelvic outlet, and then of course the pubic arch relative to it. So this is usually a very good anatomical landmark, something you look for. And of course, once you see this, of course, this is the posterior and this is the frontal or ventral area as it relates to the setup there. So with the pelvis, right, the pelvis is broader and shallower than the males with a larger pelvic outlet and outlet, as we mentioned, and that, of course, is for delivery. Another thing as well is the ischium. Where is the ischium? Where are you? Oh, the coccyx here. With females, the coccyx, this part here, is usually straighter than with males. Now, why do you think it's straighter? For a very simple reason. So with the males, you have more curvature. With the females, it's usually straighter. Why do you think that is so? All right. I'll give you a hint. It has to do with pregnancy. And you see this more in SNF2 when you're looking at reproduction. Why do you think then with the female, you'd have it straighter? It's straighter as opposed to it being curved for pregnancy. It has something to do with pregnancy. What do you think? Well, let's say if in terms of the delivery process, in terms of the baby's head coming through, you wouldn't want this joking the baby, right? Joke. If it was curved, and because you do have to remember, during the pregnancy, you do have pressure from the fluid that is present within the abdominal area. And that could actually force the head, closer to this region. So you don't want piercing, of course, of that membrane to let out, all the fluid. So one of the major reasons why when you're looking at the skeleton of a female, this is usually straighter than a male in terms of the coccyx region. All right, so now we are looking at the lower limb. We have the thigh, leg, and the foot, the ankle joint, knee joint, and hip joint, right? Mentioned already in terms of the hip joint, this is one joint you definitely don't want to play around with. So you can see this is probably a male, note the curvature of the coccyx, particularly as you get older. Because what happens in, let's say, for older persons, one, the healing process is delayed because of the fact the bone density it decreases with age. So if you do get a fracture in your hip, it takes longer to heal. Two, because of the fact you have your legs pivoting around the hip, it keeps in motion, and that makes it even harder for the healing process to occur. And when the healing process doesn't occur, what does that do? It's a domino effect. Healing doesn't occur, it promotes infection. Infection leads to strain on the immune system. Strain on the immune system leads to overall weakness in terms of the person. Now, the person is already advanced in years, and then when you advance in years as well, your immune system begins to slow down. So therefore, your immune system is more compromised. And sometimes this could lead to, from very simple, somebody get a fracture of the hip, within a relatively short space of time, next thing you hear, the person has passed. This is for older persons. So which is why it's always important, if you do have older persons around you or members of your family or even persons within earshot who could listen, it's very important that they don't fall. Right, fall is if they fall and get a fracture of the hip, it just makes it a little more complicated in terms of probably already pre-existing conditions. Doesn't mean they necessarily always will die in a short space of time, but it complicates matters. So all that being said, with older persons, if you do have them in your family or what have you not, always ensure that they don't have, let's say, toys on the ground or things that could make them fall. That's very important. All right, so let's look at the articulation of the femur, shall we? So we looked at it, we mentioned it just now in terms of the nice articulation here with the pelvis itself, in terms of the femur. The head of the femur articulates very well with the pelvic bone. So in terms of the bone itself, you have a shaft, the trochanter, the greater trochanter is shown here. And then on the other side, you have articulation again with the epicondyle region with the patella or the knee, right? Very importantly there. And this is just showing here the hip joint in sectional view, right? So here we are seeing that nice acetabulum, we mentioned that, right? That was the blue area, the blue region, which was highlighted when we were looking at the pelvis. And here we see that joint, the head and the head of the femur, how it articulates so well within this capsule, of course. So very importantly there, you see you have a synovial joint in which you have synovial fluid within the capsule itself. Notwithstanding the capsule, you also have some nice ligaments. You don't have to know the name of the ligaments. Suffice it to say, to note, of course, bone-to-bone linkage, you have these ligaments which help with the leg itself. All right, we're almost there. We have 3 more slides, the bones of the leg. This is showing the tibia also, and the fibula. Tibia is which one of these two is your shin bone? Your tibia or your fibula? Which one is known as your shin bone? The tibia or the fibula?
Fibula.
Tibia, yeah, very good. Right, so the tibia, also known as a shin bone, that's the one to the front. All right, so you can reach down and knock your tibia. Yeah, that's a very hard bone, particularly for persons who have played football, particularly for persons who played, anybody here played hockey, field hockey? Yeah, because you get hit with the stick virtually all the time. But of course, you wear shin pads, right? But it offers a lot of protection. It's a very solid bone. Now, on the topic of bones, I didn't mention it just now. If you will just jump back one. The femur, this is the hardest bone actually in the body. In terms, when I say hardest, in terms of taking stress, this bone could take the most amount of stress in your body, your femur. Right? It's the strongest bone in the body because as you could imagine, it takes most of the weight, supports most of the weight of the body itself, even though some is transferred to the tibia and fibula. But this actually takes it. So this is the strongest bone of your body itself. So by extension, this one is probably the most difficult to fracture because of the fact just by the way it's made, it could take a lot of weight. It takes a lot of weight, a lot of stress. It could take a lot of stress before fractures occur in terms of the femur. All right, let's get back to the bones, the other bones of the leg, particularly the tibia or your shin bone. Very important, as I mentioned, and it's also a very strong bone, right? Because again, the weight transferred from the body goes through the femur, and then by extension, is transferred down the tibia itself. At the end, you have the medial and lateral malleolus. These bones, as you can see, they just come over and they actually anchor the tibia to the leg. So let's have a look at the knee joint. This is just showing the joint itself. And again, in section, you see the femur and the tibia. Femur, strongest bone in the body, and then your tibia, right, is showing the shin bone in section. Note well the muscles which are also associated with them. You have the quadricep muscle, very important, and then you have, of course, tendon, because tendon attaches to the muscle itself, which anchors the bone. And then we're not seeing the ligament. So ligament is bone to bone, showing the attachment then of the patella to the tibia. So the patellar ligament actually connects the patella or your kneecap to the tibia itself. So your kneecap doesn't just float there, but it does have ligaments which hold it in place. And those are 2 important things to take note of. The muscle, particularly the quadricep muscle, and also the patellar ligament, which holds the kneecap in place as it relates to the tibia and femur. And the last diagram we'll be looking at, or the last slide for today, we'll be looking at the foot. So when we're looking at the foot, of course, we have usually 1, 2, 3, 4, 5 toes. Some people do have fusion of toes, and they sometimes it does. You don't have complete apoptosis of the area between the toes during embryogenesis. So some people do have fused toes, right? Or they do have a webbing that occurs between them. But in general, in terms of the foot, how is it arranged? You have the phalanges, metatarsals, the cuneiforms, and also the tarsal bones. Right, so the cuneiforms very similar to the wrist bones. Yeah, these are the ones you don't want to actually get fractured because they're small, they're difficult to actually keep in place in terms of healing process. Unless you're good and you put it in a cast and you're lying down on a bed, that's fine, right? So that's always, do keep that in mind. But do take note also of the bones of the foot in terms of the phalanges. This one, of course, is the distal phalanx, middle and proximal phalanx as related to those bones. There, the cuneiforms is showing the bones associated with them here. Let's look at the lateral view. Here is your calcaneus, also known as your heel. So right above it, you would have your, what tendon do we have right above it again? Anybody remembers? Begins with A. I think I gave the story yesterday. And how it, well, it wasn't, I revisited it. It wasn't the gods that actually dipped him in the river Styx. Actually, was his mother who actually dipped him in the river Styx. And of course, to dip him in the Styx, she held him right here, you know, by both ankles and dipped him in. So this was his weak point, the Achilles tendon. Right, so if you do get this tendon cut, it's a very thick tendon. It attaches to your gastrocnemius muscle. So it connects the gastrocnemius muscle to the calcaneus bone. Right, it's a very thick tendon. And if you do get that tendon ruptured or significantly cut, yeah, you wouldn't be able to move your foot. It could be repaired by surgery, of course, but in the short term, you wouldn't be able to move. You'd have to drag yourself, but you would lose that ability to flex, right? Dorsiflexion, you wouldn't have that motion at all, right? And this is just showing the posterior view in terms of the arch, medial arch, and the lateral arch, medial closer to the inner portion of the feet. The lateral arch is the arch associated with the outer part of the foot itself. All right, let me ask one final question. What bone articulates with the fifth metatarsal? What bone articulates with the fifth metatarsal? So what bone articulates with the fifth metatarsal? Say it loud, say it proud. Which one? Which bone? Fifth metatarsal. Yes? Which one is it? The fifth metatarsal, which one articulates with it or is connected to it, to the fifth metatarsal?
So long bone.
The long bone, let me see, long bone. You're looking at the foot A? You're looking at diagram A of the foot? I just say where the long bone is.
Is it the,
Oh, I know
is
what
it the calcaneus?
I know what you're thinking about. Oh, when you say long bone, I understand. You're thinking, okay, you're thinking about the tibia in terms of the tibia. Yeah, but you'll be correct, but that one is not directly attached to it. So you're partially right. Somebody said the calcaneus. Look a little bit higher than the calcaneus. What is the bone past the calcaneus? There's one bone. That's between the calcaneus and the fifth metatarsal. Which bone is that? So between the calcaneus and the fifth metatarsal, what bone do we have?
Sure.
Yes? Go ahead.
Yes.
Which bone?
Baseball.
The base? Well, the base isn't a bone. That's just the base of the bone. So you're getting closer. So between the base and the calcaneus, which bone do you have?
Sharps.
The pardon? Oh no, the other direction. We're going towards the heel. So between the base and the calcaneus, there's one bone. Begins with C. And it watching you.
It's a cuboid.
What?
Cuboid, yes, yes. The cuboid bone. And yes, it was watching you and giggling. Right? Quite right. So that's the bone that articulates with the metatarsal. It's the cuboid bone. All right, very good. So today what we looked at an overview of bones. We mentioned their structures and most importantly, how they articulate with one another. Very fascinating in terms of an engineering feat. We mentioned the two divisions, the axial and appendicular skeletons. The axial skeleton consisting of the skull, vertebral columns, and ribs, whereas the appendicular skeletons consist of the two girdles, axial and appendicular, together with the limbs or the associated bones, namely in terms of the arms and then the legs. Then we looked in a little more detail at the structures associated with them. Did mention the trochlea in terms of that joint that articulates with different structures. So for instance, in the arm, you have the humerus, radius, and ulna, and then you have the trochlea from the humerus articulating very nicely with the radius and ulna. We also looked at the structure of the hand and mentioned, of course, with the wrist bones, the cuneiforms, you don't want them to get too much injury in not too much injury, but you wouldn't want them to get injured because of the fact they're so small and they move a lot, right? So you wouldn't want the wrist bones to get injured. We moved from there, we also then went down to the other appendicular structure in terms of the pelvic joint, pelvic girdle, and the associated femur, tibia, and fibula. We mentioned with the pelvic girdle that how for the females who have more flaring of the pelvic girdle, and of course the inlet, the pelvic inlet is larger. Also at the base, the coccyx tends to be straighter and not as curved in terms of is straighter in the female and more curved in the male, ideally for protection for the developing embryo. That is important there. We then looked at the structure of the tibia, fibula in a little more detail in terms of the articulation with the femur. Then we went to the foot, right? And we looked at the organization, the phalanges, metatarsals, cuneiforms, and tarsals. And finally, we mentioned, of course, the bone that articulates with the fifth metatarsal, of course, is the cuboid bone. All right, so we'll start.
Before
Yes?
you go, I just want to ask a question. I don't know if you